So good morning to you all, and thank you for joining us. So Silvia and I, Professor Canecki and I, are going to introduce new Croatian Endocrine Society guidelines on management and treatment of acromegaly. Next slide, please. Thank you. So the previous guidelines by our Croatian Endocrine Society were published pretty long time ago, so 12 years ago to be exact, in 2012. And that's why we thought that this was the right time to write new ones and update the guidelines.
So we all are aware that chronic exposure to elevated levels of growth hormone influence both morbidity and mortality. So diagnosing and treating of acromegaly should not be delayed. So what is the first step in diagnostic process? IGF-1 levels are first assessed as they remain consistently elevated in acromegaly despite fluctuation in growth hormone levels. Normal IGF-1 levels varies with age and gender, and reference ranges must be adjusted accordingly. So, elevated IGF-1 levels above the age and sex match reference range strongly suggest acromegaly, and in patients with typical clinical signs and symptoms of acromegaly, IGF-1 levels above 1.3 of upper limit normal for age confirms the diagnosis. Well, in minority of patients with equivocal results, IGF-1 measurement can be repeated and OGTT might be additionally useful. After administration of 75 grams of glucose solution, growth hormone levels should be assessed after 30, 60, 90, and 120 minutes. And in acromegaly, there is a failure of suppression with growth hormone remaining above 1 nanogram per milliliter. If we use ultrasensitive assays, this limit could be lower with a threshold of 0.3 nanograms per milliliter. We should, of course, have in mind that there is inverse correlation between BMI and growth hormone levels. So BMI-based growth hormone nadir cutoffs are less than 0.4 micrograms per liter for BMI lower than 25 and less than 0.2 microgram per liter for BMI above 25 kilograms per meter square.
So after biochemical assessment, we should perform an imaging studies. Next slide, please. The method of choice for imaging studies is a gadolinium-enhanced pituitary MRI at the time of diagnosis. Of course, this should include a revised Knox rate, and as you all know, Knox rate helps us to determine the probability of the infiltration of cavernous sinus by pituitary macroadenoma.
So, what about treatment? Transphenyidal surgery is preferred first-line treatment in majority of cases. Microadenomas, tumors smaller than 10 millimeters, has a high success rate with transphenyidal surgery with remission rates exceeding 80%. In macroadenomas, this remission rate is lower. It is around 50 to 60% due to incomplete tumor removal, particularly if the adenoma has invaded surrounding structures like the cavernous sinus. Pathology reports should obligatory include immunohistochemistry assessment for pituitary hormones and proliferation index, and optionally additional information such as quantification of somatostatin receptor subtypes.
So after performing surgery, we should determine if the patient has achieved remission. In determining biochemical remission, we should determine IGF-1 after 6 to 12 weeks postoperatively, and we can perform early measurement of growth hormone on 1st to 14th day. It can tell us if the degree of the removal is okay and help us to predict a long-term remission. Of course, the biochemical remission is not the only thing that we should assess in acromegaly as post-operative remission. Besides biochemical evaluation, we should also assess clinical signs and symptoms and, of course, reduction of the pituitary tumor bulk or its GH-secreting remnant. So as already Mladen told us, Professor Krnić and Professor Doknić, the biochemical evaluation is not, it is the cornerstone of the post-operative assessment, but it should always be taken into account with the context of clinical signs and symptoms and the imaging studies or tumor volume reduction.
Well, after surgery, pharmacotherapy plays a crucial role in managing patients. Pharmacotherapy is indicated if there are contraindications for surgical treatment preoperatively for 3 to 6 months in patients with a high operative risk due to comorbidities, if patients who require additional control of GH levels post-surgery, in patients who have incomplete surgical resection, and in a time interval until reaching the maximum radiotherapy effect. So, regarding the pharmacotherapy, we have 3 groups of medications: somatostatin receptor ligands, octreotide, lanreotide, and pasireotide, growth hormone receptor antagonists, pegvisomant, and dopamine agonists, cabergoline. So, first generation somatostatin receptor ligands, octreotide and lanreotide, acts mainly on receptor subtypes 2 and 5, which by activation reduce the secretion of growth hormone from the adenoma. These drugs are associated with normalization of IGF-1 levels in about 50 to 70% of cases. Indications for their use are if there are contraindication for surgical treatment, preoperatively for 3 to 6 months, in patients with high operative risk due to comorbidities, if the disease was not controlled by surgical treatment, and in a time interval until reaching the maximum radiotherapy effect. Common side effects of these drugs are GI disturbances and gallstones.
So next are the second generation somatostatin analogs, pasireotide. Pasireotide has the greatest affinity for the somatostatin subtype 5 receptors, and it achieves IGF normalization in 20% of patients who are resistant to first-gen somatostatin analogs therapy. It has a strong anti-tumor efficacy because it lowers tumor size by 40% in around 80% of treated patients. Indications for use is after unsuccessful first-gen somatostatin analogs treatment with a large tumor remnant or severe headaches. In patients with clinically aggressive tumors with high Ki-67, with proximity to hyasm or cavernous sinus, and if surgical treatment is not warranted. And if the pegvisomant treatment is not tolerated or not effective. Common side effects include hyperglycemia due to its effects on glucose metabolism. Primarily, it impairs insulin and incretin secretion. Next slide. Thank you. The next drug class in question is growth hormone receptor antagonist, pegvisomant. Pegvisomant directly blocks the effects of growth hormone on peripheral tissues, preventing the production of IGF-1. Biochemical control is high. It is achieved in over 70% of patients. However, it does not affect the tumor size or circulating growth hormone levels. Its indications for use is in patients who are resistant to first-gen somatostatin analogs, particularly in patients with diabetes, in patients not treated by the size of, not threatened by the size of residual tumor, and when somatostatin analogs alone are insufficient for controlling of IGF-1 levels. Common side effects include transient liver enzyme elevation. That's why liver function tests should be monitored regularly every 4 to 6 weeks in the first 6 months of treatment and discontinued if the level of liver enzymes is 5-fold above the upper limit of reference range. Next class is dopamine receptor agonist, cabergoline. Its mechanism of action is that it directly binds to the pituitary D2 receptors to inhibit growth hormone secretion. Its efficacy is low. It normalizes IGF levels in only 10 to 30% of patients. However, it is really cost-effective. And its indications for use is in patients with mild acromegaly with IGF-1 levels below 1.5 times the upper limit range, in patients with mixed somatotrope lactotrope pituitary adenomas before surgery or if remission is not achieved by surgery, and as add-on treatment in patients partially responding to first generation of somatostatin analogs. Its common side effects are mild nausea, dizziness, and headaches, and higher doses have been associated with valvular heart disease. And last is the combination therapy. We have already heard something about that. So in combination therapy, low-dose octreotide LAR or lanreotide are combined with weekly pegvisomant. It is often used when somatostatin analogs are insufficient for controlling of disease. It allows better control of IGF levels because we are able to reduce the dosage of the drugs and potentially minimize side effects, and of course it allows to be more cost effective. The second combination, which was quite recently introduced, is pasireotide and pegvisomant, also weekly, can result in biochemical control rates over 70% of patients, and it has no effect on pasireotide-induced hyperglycemia. And last combination is low-dose octreotide on lanreotide with cabergoline. Combining these agents can be effective in patients with mild to moderate disease, especially in those with combination of secretion of prolactin and growth hormone.
About radiotherapy, we differs conventional fractionated radiotherapy and stereotactic radiosurgery. And this kind of therapy is reserved for patients who are not candidates for surgery due to medical risk, have residual or recurrent tumor after surgery, do not achieve biochemical control with medications such as somatostatin receptor ligands, GH receptor antagonists or dopamine agonists, and in those who prefer to avoid or discontinue long-term medical therapy due to side effects or costs. Radiotherapy is third-line treatment due to delayed effects and potential for complications such as hypopituitarism, because full effects of radiotherapy take years to manifest. Close monitoring of hormones levels and tumor size is necessary, and because patients may require interim medical therapy to control their symptoms while awaiting the delayed effects of radiation.
After surgery and medical therapy is the second-line option, and radiotherapy is the third-line option, we have to assess the remission. So assessment of the postoperative remission includes the determining of IGF-1 after 6 to 12 weeks postoperatively, and then IGF-1 every 3 to 6 months in the first year. IGF-1 should be consequently determined every 6 to 12 months afterwards. First MRI should be performed 3 to 6 months postoperatively, and then follow-up MRI should be performed in following cases: when clinical and biochemical signs of progression exists, in persistent hypersecretion of growth hormone, when changing the management plan, and before before other surgery or radiotherapy. When assessing remission with pharmacotherapy, IGF-1 should be determined after 3 months and then 6 to 12 months afterwards. When treatment is started with cabergoline or pegoisomant, IGF-1 should be determined 1 to 3 months after starting adjusting the dose, and then 6 to 12 months afterwards. Growth hormone in those cases is not informative. After radiotherapy, pharmacotherapy should be stopped once per year to check for remission. When attaining a remission, once the remission is attained, maintaining IGF-1 in mid-normal reference range should always be the goal.
So it was stressed earlier that it's very important also to follow metabolic and endocrine disorders in these patients. So we advised that fasting blood glucose should be checked every 6 months, particularly in uncontrolled disease and during somatostatin receptor ligands therapy. HbA1c should be assessed every 6 months if patient have diabetes or pre-diabetes. Total testosterone, sex hormone binding globulin and prolactin should be checked annually in males. Of course, in some patients, testing of free testosterone is advisable. In females patients, LH, FSH, estradiol, and prolactin should be checked annually, and in premenopausal females with menstrual dysfunctions and when pregnancy is desired. Serum free T4 and TSH should be checked annually. Serum cortisol levels if central adrenal insufficiency is suspected, and cosentropin stimulation tests should be performed if serum cortisol is low, and if we suspect that patient have obstructive sleep apnea, we should perform Epworth scale or polysomnography.
Then we have to follow for cardiovascular disorders. Blood pressure measurement should be performed at baseline, and then every 6 months or upon change of antihypertensive treatment, ECG and 24-hour Holter ECG annually if abnormal, echocardiography annually if abnormal. DXA densitometry should be performed every 2 years, particularly if osteopenia or osteoporosis are present, and thoracic and lumbar spine X-ray annually, particularly if history of vertebral fractures exists, a decrease in BMD, kyphosis, scoliosis, and symptoms of vertebral fracture, and in the cases of untreated hypogonadism. Cancer, we should perform colonoscopy every 10 years, more frequently if IGF-1 remains persistently elevated or if abnormal colonoscopy or family history of colon cancer exists. And we should also perform thyroid ultrasound when acromegaly is diagnosed, and later depending on the initial finding. Of course, we should always check for the quality of life by using AcroQL annually. So this was the short introduction of our new Croatian guidelines. I hope it was a good one, but however, this is the first draft version. So I would like to invite you all to leave your comments and suggestions via our official email, and we will incorporate them to our guidelines. Thank you so much.
Thank you.